Hi everybody, welcome back. Sam Lewis of Sam's Diamonds here. Welcome to one of our next talks for our C Positive event. And today we are talking to Emma De Souza. Now Emma is, I'll call you Ms. De Souza. Is that better, or do you prefer Emma?
Whatever, Emma's fine.
Okay, so Emma is a consultant oncoplastic breast surgeon at the Royal Liverpool University Hospital, where she is based in the Linda McCartney Centre. She is vastly experienced in all fields of breast surgery, and her expertise cover breast cancer surgery, breast reconstruction, revisional surgery, risk-reducing surgery, fat transfer, nipple surgery, and cosmetic surgery for large, small, droopy, and asymmetrical breasts. So today we're going to be talking everything to do with surgery on all those parts. I've had one question already that I've had from one lady. So Sarah, I will ask your question a little bit later. And if you do get a question that you want an answer to, just write it down and we'll get you to ask them all at the end, if that's okay, so we can just let it flow. So Emma, can you introduce yourself? Tell us all about you and what you do.
Thank you very much. Thank you, Sam, for inviting me. I'm very honoured to join this conference over these next 2 days. It looks like there's some really great speakers and some interesting topics to cover, and it's really lovely to be part of it. As Sam has already said, I am a breast surgeon in Liverpool and in Manchester, so across the northwest essentially. And just a little bit of my background, I have always lived in the northwest since I was about 2 years old. And I've done most of my training up in this region. However, I've had 3 stints away. I was at university in Oxford way back 20-30 years ago. I have also done some molecular research for 2 or 3 years over in Melbourne in Australia, which was great fun. And I sort of went to my finishing school for breast surgeons when I went to Nottingham for a year as part of a fellowship, just before I became a consultant. And I've been a consultant since 2014. So yeah, 6-7 years now. As I said, I work across Liverpool and Manchester. Liverpool is my NHS post at the Royal in Liverpool. Manchester, I work at the Alex in Cheadle and soon to be the Winslow Hospital as well. And so, as Sam says, I'm an oncoplastic, reconstructive and cosmetic breast surgeon, essentially. Just to let you know what that means in reality. I'm the first person you meet when you're referred to the hospital with any breast problems. I'm also the first person you meet if you've gone through breast screening and we identify a problem, you have a biopsy, and then you come back for your results. So I'm often the coordinator of all the treatments that you have if you are unlucky enough to be diagnosed. And although you will meet other professionals, and I'm part of a big team such as the oncologists, the chemotherapy doctors, the radiologists, the pathologists, we all work as a team. It's often the surgeon who you stay under their care for the full duration of your treatment, up to 5 years, some occasionally 10 years, but often 5 years. So yes, I'm the one who gives you a diagnosis, but I'm also part of your treatment. The surgery is the mainstay of treatment for breast cancer. It's not the only treatment, and sometimes it's not appropriate for everybody. But for the majority of people, there will be some surgery at some stage in their journey. And so that's where I come in. And so today, really, I just wanted to talk to you about breast surgery in general. I'm very happy to open it up and focus on whatever you really want to hear about. But I just want to give you an idea of what's involved in the decision making, what influences our decision making, and how we go about that, and go from there, really. So back to you, Sam, if that's all right.
That would really be interesting, to be honest with you. One of the questions I just want to ask before you get into all that is, what made you decide to do this? What made you go, I know what I'll do, I'll help people? Was it like, did you have usually people have a history, like somebody in their family got it, so they decided they wanted to become a surgeon, help with it, or was it just?
No, I grew up in a surgical house. My dad was a surgeon, so yes, I knew what was involved, but I don't think that made me do it. It meant that I went into it with my eyes open, and I knew the commitment I was making, but I also knew the benefits. I knew the job satisfaction you can get from it. So that's fantastic. But I went into medical school not knowing what specialty I would choose, and very quickly, I guess different people are different in the way they make all their choices in life. I'm a very gut reaction sort of person. very quickly enjoyed the surgical specialties much more than the medical specialties, where we treat people with medications or just with minor interventions. I then found that within the surgical specialty, I just enjoyed looking after the breast patients. I like the journey. I've already partially described it to you, but it is, you start with a lady who doesn't know what she's facing, and we guide them through it. And when we're part of the treatment as well, so we can do something really positive. With reconstruction, it's fantastic, or with some of the oncoplastic work, it can feel very destructive, the fact that as surgeons we're taking something away and we're removing something, but actually we can put something back as well, and we can put a very positive spin on it with the breast reduction type of surgery that we do, or with the reconstruction. So it feels very constructive as well as ablative, and I like that aspect of it. So it's all over, and it's sort of the whole package really that I've always loved. I think ever since I was a medical student, my third year course medical student, I knew what I wanted to do, and so I tailored my whole training to that.
I think you kind of get the full spectrum of emotions though, don't you? Where you've got to tell somebody, unfortunately, you know, it's something that's inoperable maybe, and then to the other end where they're walking around like, yes, look at me, and they can't stop getting the boobs out for everybody.
Exactly. And when I first meet people, I tell them it may be a year, 2 years journey before they really feel back to their normal selves sometimes. And they don't believe me, but then when I see them a year, 18 months later, with a big smile on their faces, it's fantastic. It's a good feeling.
And you can go, I did that.
Yeah, we can do our best, can't we? And that's what we do every time, and it's nice when things work out, and it's fantastic.
And you know what, I think just talking to you yourself, I can see that you're very friendly, very approachable, and this is something that is really needed when you're about to take a body part off someone. They're frightened to death. I mean, I remember my surgeon, I don't know whether you know Professor Odissio, if you remember him. Yes, he sang me to sleep with his Italian accent and everything, and that I will never forget, because it was just that extra little bit of a touch that relaxed me, you know. And it must be really hard for you to speak to somebody about their diet. I mean, how do you handle giving bad news as well as good news? Is it, I don't think I could do it. That's all the reason I'm asking. I'd just be crying in a mess with them all.
How do you do it? You have to put yourself a little bit in their shoes. So I try and find out about the patient and what makes them tick. I had a very, very good trainer when I was in Nottingham who used to teach me to talk for 5 or 10 minutes to my patients even before I started talking about cancer, and just find out about them as people. And I think that's really important. Most people want to know the results of their biopsies as soon as they've walked in the door, so it doesn't always work like that. But I still spend a lot of time asking them who's important in their lives, what do they do in their spare time, and just trying to understand them as a person, because that way you can help them in their decision making much more. And I think that helps a lot. We get a lot of training when we're younger about our communication skills, and to make sure hopefully we do give you the information in the way that is acceptable and is kind and is considerate at all times. And I don't think all doctors get it right all the time, and I'm sure I don't at times, but we all do our best, and you can guarantee every doctor who's doing it is doing it with the very best intentions, even if they don't always hit the mark. They're still human beings, and they still sometimes get upset with what we see and we do. And if the day I stop getting upset is the day I should stop doing my job.
I agree.
And so and I've been doing it for years.
And you still love it.
I still love it. Yes, and I think enjoying your job is a really important part of being able to do it well.
To know that you're saving lives every day must be
I know people say that to me. I don't think of it like that though. You know, that's not how.
Oh no, that's really, really good. I actually don't think I could do it. I've got to be honest, I don't think I could actually do it. So I will get onto the topic in a second, but were you like the type of, I'm just thinking of my children, you see, I've got a child who enjoys gore. She's obviously a girl, enjoys gore, nothing puts her off. She loves playing with dough. She's very tactile. She's very like ins and outs of it. Were you like that as a child? Is that why you think you got into all that?
I don't know why I went into surgery. I was musical, I was sporty. I wasn't particularly crafty or creative. I did sewing more than when I went to medical school. I picked up a sewing machine and started just making patchworks and stuff like that as a young adult, really. I suppose I did make soft toys, I suppose, and did some sewing when I was a child also. So I didn't really think of myself as particularly crafty. Certainly didn't like gore and blood or anything like that. But I don't still think of what I do as particularly gory. But again,
really,
I've grown up with it, and I suppose that it just doesn't. I don't notice it in that way. I don't think of it like that. It's a technical. And it's something very specific I have to do, and a project. You know, each patient is a task that I have to complete to the best of my ability, and that's just how I see it. And I don't think of it as gory as
so would
such.
you say you're a bit of a perfectionist then?
Probably. I think you have to ask my trainees and my junior doctors and my patients.
You'd have to be, wouldn't you? You'd have to be, really.
Yes,
so
I would say.
Can you tell me then what types of, so I've come in, I've got breast cancer, I need some kind of operation. What types of surgery are there? What are my options? So what types of surgery are there that you could do for a mastectomy, say?
So we could break it down very simply. The lump needs removing, or the area of disease. Sometimes it's not a lump, we can't feel it, it's just a mammogram that it's been picked up, but that area needs removing. And so the assessment then turns to how much, as a proportion of the breast, does this area take up? Because that helps us make the decision about whether it takes up too much of the breast that there's not enough to salvage, in which case we're looking at a mastectomy, or whether it's taking over a small amount of the breast and we can still leave a nice breast-shaped breast left at the end. Mm-hmm. And I know that sounds very simple, but actually that's what it boils down to. And then a lot of the surgical techniques we have are for crossing the boundaries in the middle, where it's medium size, it might be taking up a quarter or a third of the breast, and whether we're able to preserve the rest of it by bringing some extra volume in, or whether in fact it's taking over half the breast volume, in which case we're looking at a mastectomy. So it's not about how bad or aggressive or nasty your cancer is very often, although there are a few cancers in particular where we always recommend a mastectomy. It's more about the proportion of the cancer versus this as a proportion of the size of your breast. So somebody with an A-cup breast with a 2 centimetre cancer may well still be recommended a mastectomy, whereas somebody with a G or a H-cup breast may well get away with just a simple lumpectomy. Mm-hmm. And ladies in between may need some sort of partial reconstruction or a breast reduction type of technique to take away a significant proportion of it and reshape the breast into a nice shape at the end. And so then it is very variable.
The other one as well, wouldn't you, to match it? Obviously, if you're doing a reduction on one.
If you're doing that, yes. Sometimes you can get away with a small reduction type of technique that doesn't leave you too imbalanced, and then some ladies are quite happy to have a little bit of asymmetry and don't want the other side to be touched because there's nothing wrong with that side. Other ladies, that's where we can give something back, and we can actually, they've wanted a breast reduction all their lives, and suddenly we can do that for them and leave them with the pair of breasts they've always dreamed of and get rid of the cancer at the same time. That's really nice.
Wowza. I know that a lot of our ladies over the years have always got excited. It's bizarre, isn't it? You're losing a breast, but they're excited about it because they get a tummy tuck and they get a new one built, you know, and they're like, oh, I'm going in for my tummy tuck, not the mastectomy, the tummy tuck. So there is different areas that you can take, what would you call it? It's not flesh, tissue, where you take tissue from to rebuild a boob. I mean, can you talk about the different procedures that can be done in that way?
Yeah, so in this case, you're talking about ladies who are having a mastectomy, and so as you know, there are all sorts of different ways of doing a mastectomy. The simplest is to take the breast tissue and the skin overlying it and leave a lady flat, and that's what lots of my patients choose to have. It's the simplest, it's the least complex, and when you're grappling with the concept of cancer and all the other treatments that are coming with it, it's a good, simple, straightforward decision, and makes a lot of sense. Other ladies find that there's absolutely no way they could possibly conceive the idea of losing the breast and going flat and being asymmetrical. You want me to stop?
No, I just got a question on that before you go on a bit further. Sorry, I didn't realise I was on camera with my finger up. No, another thing is, a lot of ladies who know they're going flat on that side would like to go flat on the other side, but they're not allowed to. Can you explain why that is?
Okay, yeah. So I'll come back to describing the reconstructions later on. That's very simple, but it's controversial, and it's around the fact that going flat on the other side will not improve their long-term outcome usually.
Right.
So there's been lots and lots of studies that say to have the contralateral mastectomy does not, is not in any way therapeutic as far as your risk of cancer goes. Your risk of cancer comes from your index, your original cancer. And if you were unlucky and got cancer on the second side, it's likely it'll be picked up earlier. It'll be very treatable. And the biggest threat to you is from the other side. That said, we're all very sympathetic to the fact that it's your body, not ours.
Yeah.
And what we try and do is make sure you don't make any rash decisions in the heat of the moment when you are having your cancer treatments, because it is such an emotional time, and it's much better to see if you can live with that asymmetry for a number of years. Most ladies get very used to it, very comfortable with it, and are very pleased that they didn't make that decision at the beginning, even though their instinct at the beginning was to have an operation on the other side as well. In retrospect, most of them, after time, much prefer the fact that they've actually managed to keep the other breast. For a number of reasons. A bilateral mastectomy is very difficult to live with if you don't have a reconstruction. A bra doesn't sit very easily. It is a very different body shape and a very different aesthetic to cope with if you're flat both sides. And although ladies say they think they can cope with it, I've had a couple of ladies for whom I have done it who've begged me for, and have been through a lot of psychological examination and assessment before we agree to it. And they still afterwards say, I didn't realise how big this operation would be.
Really?
And so I talk them out of it before I'm talked into it, is my policy. And that's a very deliberate policy to make sure I'm protecting them from their initial instincts. If ladies 2, 3, 4 years down the line are still having enormous anxiety problems and depression and all sorts of other aspects that go along with the worry about recurrence of breast cancer or a new breast cancer on the other side, then we do consider it, and we do it occasionally. So that's for going flat both sides. Just prostheses, there's nothing for your bra to catch underneath of it. So the practical aspects of it get quite difficult. Whereas if you only have one side, then your bra still sits at the right point on your chest wall, so that then when you have a prosthesis there, it doesn't ride up, and simple things like that people don't really think about until they're faced with that practical aspect to it.
I think a lot of ladies,
there are lots of issues.
Yeah, I think a lot of ladies wouldn't actually wear a bra if they were flat on both sides. And I think a lot of people, it's kind of like I'm just looking at it from my perspective and from things. I mean, I'm happy as I am with one, but if I wanted to get rid of the other one, I wouldn't be wearing a bra. I'd just embrace the flat chestedness. But then one of my little pet hates now is I can't wear a V-neck top because I have cleavage on one side and nothing on the other. But if I had nothing, I wouldn't be able to wear a V-neck top at all.
I think you would be really surprised at how the lack of a breast at all, that femininity that goes with your breast shape, is much bigger than people expect it to be. And you think, oh, well, I just wouldn't wear a bra, but in actual fact, ladies find that very difficult, and they end up wearing a bra with 2 prostheses in rather than with 1.
So if they came back to you, say 4 or 5 years after having the one mastectomy and said, listen, I really do want you to take the other. It's not because I'm worrying about cancer coming back or anything. I just want to be flat on both sides. If it wasn't causing anxiety or anything, and it was just laziness because they just wanted to be equal, is that something that you would consider then?
I haven't actually been faced with that yet.
It's always been anxiety and stuff like that.
It's usually for psychological issues rather than practical ones. Some sports people and people like that may well find it is more practical and easier to be flat both sides. You have to take every individual as in their own setting and in their own circumstances, and go from there. And I never say never is all I say to patients. I will listen, and I will be sympathetic and do as much as I can. Often when we have difficult decisions like that, we put them through our MDT. So we put them through our colleagues. I have fantastic colleagues in Liverpool and in Manchester. And I would always sit down and I would phone a friend or put them through our official meeting and say, I've got this patient, I've got these issues. What do you think? Would you assess her as well? Would you tell me whether you think this is appropriate? And we make sure that it's not one individual, there's no, and then that makes sure it's much safer decision making for everybody, including the patient.
Yeah. That's fair enough. It's a medical disciplinary team, the MDT, isn't it?
Multidisciplinary team.
Oh, I was close.
Yeah.
I was close.
So multidisciplinary, in other words, it's not just surgeons, but there's the pathologists, the oncologists, the radiologists, the nurses, the breast care nurses, yes, everybody.
Yeah, a lot of people tend to put it all on that one person. My surgeon wouldn't let me do this, and it's not just down to that one person. It is a team of people, isn't it, that make the decisions?
Yes.
Yeah,
yes.
Definitely.
And sometimes NHS restrictions, occasionally, you know, it's not funded on the NHS. It doesn't happen very often. If a cancer patient needs something, they usually get it.
Yeah.
It's usually more the cosmetic issues that may not be funded.
Gotcha. Okay, sorry, I had to throw that one in there because I thought if all the girls are watching, you've had these conversations with me and I don't put that to you, then they'll be like, why didn't you ask her? Okay, so other medical procedures, other options that they have.
So yeah, you were talking about types of reconstruction, weren't you? So I was talking about flat. I always think then that there's sort of a ladder of reconstructions that are possible, and that they are increasing in complexity as they go up the ladder. But the benefits of each of them also increases as you go up the ladder. So the simplest type of breast reconstruction is to use an implant. And that's a silicone implant. They're the same implants that are used for a boob job, for an augmentation, but they are used in a very different way, and the outcomes are very, very different. So it's a very different operation from an augmentation. It's not just about popping a silicone implant in. We will either use the implant on its own with a layer of mesh over the top of it, or we'll do a two-stage procedure where we use an expander, where we close the skin over the expander under mesh with it deflated, and we gradually inflate it up, which puts less pressure on the skin and less stress on the skin when you've just taken away a nice warm piece of breast tissue from behind it. So an implant-based reconstruction is either one stage or two stage, depending on whether we use the expander or not. And that's the majority of ladies choose to have that type of reconstruction, because the only incision is at the point where we do the mastectomy. It's on your chest wall, on your breast. Whereas the next ladder up, the next stage up, is to steal some tissue from somewhere else in the body. And that can be stolen from various different sites. If the site is close to the breast, we don't have to disconnect the tissue from its own blood supply, and therefore that can be just moved or swiveled sort of from one area to another. The main type of reconstruction is called a latissimus dorsi flap reconstruction. So that's using the latissimus dorsi, which is a muscle on the back that runs along the whole of the back from top to bottom and inserts up into your shoulder. And so we can lift it off the back with a skin paddle over the top of it, and we can bring it round to the front. And it stays on its own blood supply, and it's lovely because it's soft and it's warm and it's floppy, and it's not like an implant which is a bit stiffer. It's not a foreign body, so it doesn't have a lot of the complications that can go with an implant-based reconstruction. But obviously you have a big scar on your back, and you have a muscle that's been removed from your back as well. So if you are a windsurfer or a rock climber, you definitely wouldn't want it. Swimmers, I have plenty of patients who can swim afterwards, and they can still swim without any problems whatsoever. But if you were a sports person, you may choose not to have that operation because you don't want that muscle to be lifted and moved. And then the next level up, as far as tissue-based reconstructions go, is taking them from a site distant from your chest. And that means their blood supply has to be disconnected and has to be reconnected somewhere up onto your chest wall. So that involves microsurgery, where you're stitching the blood vessels from where they were joined lower down to where they are now joined up in your chest wall. And so that's called a free flap rather than a pedicled flap, which is what the latissimus dorsi is. So the free flap type of operations are performed by specialist microsurgeons because they use microscopes to do that anastomosis. And they are trained specifically as microsurgeons, and that's within the field of plastic surgery. So you find them at Wiston Hospital in Merseyside, or at Chester, or up at Preston. And in Manchester, it's over at Wythenshawe. And obviously around the country, it will be wherever the plastic surgeons are based. But it is not in every hospital, and it's not all breast surgeons who will perform that. And they can still, and that's the tummy operation that you were talking about before, where people get a tummy tuck at the same time. And the nice thing about that is it's skin and fat, and often you can leave the muscle behind so that there's no issue with strength of the abdominal wall in quite the same way. We make a little hole in the muscle to follow the blood vessel and get it out. but the muscle stays there and is intact and still works in the
Wow, I
future.
didn't know that. I didn't know that. I thought you actually cut the muscle a little bit. I'm thinking of cesareans, aren't I suppose?
Yes, and there's two ways. Most of the time they can do it without taking the muscle. If the blood vessel has a very wiggly course through the muscle, they sometimes have to take a little bit of the muscle as well. But in general, the majority of that flap has no muscle in it. It is mainly fat and skin from your tummy, or they can use it from your bottom or from your inner thigh. So they can take tissue from all around there. Obviously, though, you're going to have a big, long scar where they've taken it from, as well as on your chest wall. So it's double recovery. It's a longer operating time. It's a much bigger operation, and the healing time takes a lot longer, and the complications that can occur are much greater. But obviously, the benefit is then you've got a nice, soft, warm reconstruction that much more closely mimics a natural breast than a silicone implant will do. And so if it's suitable and it works, then we refer patients for that. And we guide the patients. We guide somebody when they come and they're looking for a reconstruction, what would suit best, and many ladies start with the implant-based reconstruction, and only if it doesn't work do they then go on, or they find for any reason it's not suitable for them, they go on to have the free flap or the other types. But for many ladies, the implant is sufficient.
So when you say if it doesn't work, why? What could happen to make it not work?
All sorts of things.
Really? Really? And I've heard of the one that the fat can be reabsorbed into the body. Is that possible?
That's a different complication. That's about lipofilling. That's different again. No, with implants, the problem with implants is that they're a foreign body. They're not your natural tissue, and therefore it's possible to form. We naturally form scar tissue around them called a capsule, and most of the time that just sits there as a nice kind of barrier that keeps the implant in its position. But occasionally that capsule carries on tightening and your body carries on forming scar tissue, and that can tighten over the years, and the capsule contracts to the extent that it can cause pain and it can cause a distortion of the shape. So often implant-based reconstructions will need revising as the capsule contracts and the reconstruction is distorted. That can be accelerated if ladies have had to have radiotherapy on top of it, because radiotherapy can cause more fibrosis and more problems. So that's one of the problems. The other problem is that implants in the past have had a history of rupture. Ooh. And at some stage will fail. But whether they fail at 5 years, 10 years or 25 years is very variable and totally unpredictable. And even if they do, it doesn't matter, as long as they failed within their capsule, in other words, within that scar tissue, you're not going to come to any harm anyway. Even if the capsule ruptures, you don't come to a lot of harm, but they do need removing and a fresh implant putting in, because the silicone is there and it's present, and its own capsule of the implant is broken, and therefore the silicone can in theory leak, although the silicone itself is a bit like a Roundtree's jelly, so it's very cohesive, it sticks to itself, it's not liquid, so it can't just pour out and just enter the bloodstream and go travelling around the body or anything like that. If that
did go around your body, would it be poisonous for you?
No.
Right, okay.
No, it would just create a bit of a tissue reaction. It would create a reaction, and there are some ladies who feel that they have an illness related to having breast implants, but in actual fact, that hasn't been proven scientifically at all. Right. And the bigger problem is it just creates a bit of a tissue reaction, and it needs to be solved. Otherwise, you end up, with lumps around where that silicone is. But it can't escape into the blood system anyway. Right. It's not. It's too sticky for that.
So you just get a lumpy body, like a lump appear here or here or something like that.
It would usually just be in the armpit or locally, just close by where it happens to be. But occasionally we see that. But that's one of the other problems with implant-based reconstruction. The final one I would say is infection. So there's always a risk of infection after any surgery, and infection after implant-based reconstruction is present. It's one of the known complications. We give you lots of antibiotics after your surgery. And we keep a very close eye on it. We're very keen that the wounds heal very quickly and your skin heals, because that's where bacteria can get in. But if you get infection in and around an implant, the implant has to be removed, and we can't put another one back straight away. So the implant reconstruction essentially has not been successful.
Right.
that can happen too. So there are a number of ways that implant reconstruction can have problems, but all surgery has problems. And so the free flap and the pedicle flap surgery also has its own range of problems, which I could talk about for hours, but I don't think.
But I bet you the surgery is often more successful than it is not successful anyway. So
all surgery, otherwise we wouldn't choose to do it.
Yeah. I just didn't want to
wouldn't offer you something that
we
wouldn't offer you anything that we thought was detrimental or was too risky.
Yeah.
And so for some ladies, reconstruction is not suitable. If they have other illnesses, they have other medical problems, it may well be that reconstruction just is not the right thing for them. It's too complex and the risks are too high, and then we'll make them more poorly than we will better.
Yeah, and you'd explain all that to them as well, wouldn't you? So yeah, absolutely.
And so if a surgeon doesn't offer you a reconstruction, it's often not because they don't want to, it's because they don't think it's the right thing for you, or and they'll usually explain to you why it would be more harmful than not to have that reconstruction.
Gotcha.
I often tell my patients the biggest thing for me is smoking, because I'll often tell my patients to stop smoking because their wounds don't heal as well, the tissues aren't as well perfused, and therefore the risks of any operation are higher if you're a smoker.
I didn't know that.
Things like that will influence the decision making we have with regard to which reconstruction we offer patients.
Gotcha. Okay, another question that I've been given. I should have told you all these beforehand, sorry. There's ladies who have false boobs anyway, who've gone and got a boob job.
Yeah.
Finding a lump is a lot harder for them. Can it attach on the outside of the implant, or is it easier to detect underneath? Will a mammogram or anything like that find it? Because I've had people come up to me say they're worried about getting breast cancer, but they've got 2 false boobs and they don't think they'll ever be able to find a lump, or what are they looking for?
I'd say the opposite is true. I'd say it's easier to feel a lump in a breast that's got an augmentation, because the augmentation sits behind the breast tissue. It sits between the breast and the chest wall. So it's pushing the breast tissue forward. So there's no breast tissue behind the implant, so it's not hidden by the implant.
And is it always done that way?
Yes, there's never an implant in the middle of the breast tissue. It's always behind it.
Oh, that's good.
And therefore the breast tissue is pushed forward. So between the skin and the implant, it's very easy to feel the breast tissue, and therefore feel a lump if it develops. And I would say often the ladies who come to me with lumps and who unfortunately have had breast cancer while they've had implants in, they've found quite small breast cancers as a result. They've not been big. And I think that's because the breast tissue is pushed forward and they're easier to feel. The areas that it's hardest is at the edge, where it meets the chest wall, where the implant and the breast and the skin all meet the chest wall. So around the edge, they have to feel and be careful, but also around the edge is again easy to feel. So that can be picked up. You can still do a mammogram on a lady who's had a breast implant. There's a special mammogram technique for it, so that's still possible. And all the mammographers are trained in how to perform a mammogram on the breast with implants in. So yes, and it doesn't increase your risk of having breast cancer either, having a silicone implant.
Okay.
So they shouldn't be scared. And they should have been told about all of that when they got their implants put in, but I don't know whether they do or not. And so yes, it's still okay.
That's good. Okay, so another question for you. Sorry, chemo brain's just kicked in. It came in and it went. So where was I going with that? I think there's somebody in the waiting room. So I did the false boobs thing. Oh yeah, staples, markers and stitches. Sometimes when you've had your surgery, you feel hard bits. Am I right in saying stitches dissolve?
Yes.
Could staples be left in, or could markers be left in? Is that a possibility?
Yes, not staples as such, although I suppose they look like staples on a mammogram. They're little folds of metal that are 3-4 millimeters long, which are clipped. They're actually designed to clip blood vessels as part of surgical dissection and surgical technique. But when we finished an operation, we will often leave those clips in the cavity where we've taken the breast cancer from, very deliberately, so that then when the radiotherapy team come to planning your radiotherapy, they know where the cancer came from within the breast. If you can imagine a big breast, it's difficult to know whereabouts to focus that radiotherapy beam on.
Right.
If we've left our surgical clips in the correct area, then it makes it much easier. So it's a very practical, simple way to guide the radiotherapy team when they're planning the radiotherapy. It doesn't affect you in the long run. They're inert clips. They're designed to be left in the body. I think they're made of titanium, but don't quote me on that. And they will just sit there and do nothing. They won't spark a scanner at the airport or anything like that.
Metal detector, yeah.
They won't do anything like that, and they're really an important part. And anybody who's had any surgery, they're the same sort of clips that we use in sterilisation, for example. They're the same sort of clips that you use internal in the abdomen for various surgical procedures. So anybody who's had a number of any surgical procedures has probably got some metal clips left somewhere where they've had the surgery.
Right, okay. I remembered my question. Right, so I've had a mastectomy on this side, but when I go back to get my mammograms, they do it on this side. But it's this side I'm worried about. Is there anything that they can do on this side to check for the cancer on this side?
There's no imaging that we do. There's no routine imaging that we do. It's mainly examination, because on this side, or you have your skin, you have the small layer of fat that everybody has that sits underneath the skin. And then you have the muscle of your chest wall, you have your pectoralis muscle and your serratus muscle. And so there's really nothing else there. The thing is that whenever we do a mastectomy, we say we're only taking away 99% of the breast tissue. I'm sure you will have been told that. We can't guarantee we've taken every single little cell of breast tissue, because it's the same colour as the fat that sits underneath the skin. Right. And there's no distinct plane between the two. So it's simply a question of feeling for it and examining for it. And if you notice a new lump in the skin of your chest wall, any changes, any thickenings, you'll be straight back to your doctor. Yeah. And your surgeon or whomever assesses you, the nurse practitioner in clinic. If you come to one of our clinics, it might be a nurse practitioner, but they will examine you, and then they will do further assessment of it. Obviously, you can't have a mammogram, but they will do an ultrasound scan. They may do a punch biopsy or a core biopsy of it if it is a distinct area of thickening compared with the rest of your skin and your chest wall. So there's still ways that we can assess it, but there aren't routine surveillance techniques that we use. If we wanted to do further, there are lots of fancy imaging techniques that we can use. If necessary, we need to look further afield, but usually that's... So
it's only if you actually find something really that they'll check on that side. But it's hard, isn't it? Because as soon as you've had the surgery and you've healed enough, you do have lumps there, like jelly lumps, don't you?
Surgery creates scarring. It creates scarring, and that scarring gets fibrosed and thickened and becomes hard and lumpy.
And people
it's the same. And it's the same for ladies who've had a breast reduction, who've had any form of breast surgery. They will have lumpiness within their breasts. And it's a question of learning what your normal is and what your new normal is, to quote a new phrase, the COVID phrase. Whatever the new normal is, that's yours, and you have to learn it. And then it's when there's a change from that then, if you get that assessed if needed. But obviously, that's for everybody who's had any surgery of any description. It's always lumpy and thickened.
Yeah. Okay, I've got a question of one of our ladies, Sarah. I know she's listening. She asked me to bring this up to the lymphedema nurse, but I think it actually comes under your jurisdiction, if you want to call it that. Is it normal to still be getting fluid or seroma in a mastectomy scar 11 months after? Would this have an impact on what reconstruction I can have?
Okay, so it's uncommon to get persistent seromas after any surgery. Hello, Sarah. But it's not unheard of, and it's an unusual and a difficult problem to solve if you get persistent seromas. We have a number of things that we can try and inject into cavities to try and stop them producing fluid, but the longer it goes on, sometimes the harder it is to do that, and it's a difficult problem to solve. Sometimes people end up having more surgery just to try and remove the lining of the seroma cavity to try and reduce the amount of seroma that's building up. As far as reconstruction goes, I can't see why it would be a problem in its own right to prevent you from having some form of delayed reconstruction. You should be able to still have that. I suspect that what somebody would do is at the time of that delayed reconstruction would be to try and again remove the lining of that cavity that's producing the seroma the whole time. I think one of the bigger things might be to think about is why has it formed in the first place? Maybe it's radiotherapy. I don't know if that's the key. If you've had radiotherapy to the chest wall, sometimes that delays healing, and there's altered healing mechanisms that go on after radiotherapy that might mean that the seroma is an ongoing issue. And radiotherapy to skin doesn't heal as well. So when we're thinking about reconstruction, we have to be a little bit more clever about what types of reconstruction we offer to somebody who's had radiotherapy to that chest wall. So yes, there are definitely more complex things to think about if you have a recurrent or a persistent seroma. And if you've had radiotherapy there as well, it may limit what types of reconstruction you can have, but it doesn't in itself prevent reconstruction from being offered. But your surgeon would be the one who would assess all the different issues, all the health issues in general, and come up with a plan for you that could work for you. And that's how I would approach it. Certainly, and it's often a process. It's not a yes or no. It's a let's see if this will work or that'll work, and see if we can come up with something that will work, that will fit the bill.
Pulling different things out of the kit bag until we find one that works. It's the only way you can do it, isn't it? As you say, it's not one hat fits all. Everybody's bodies are different, everything, isn't it? So you've just got to have lots in there. If there's anybody else,
does that answer the question for you, Sarah? Does that help? That yes.
Yeah, thank you there. Yeah. If anybody's got any other questions that they would like to ask, yes, it does. She's put. If you put it in the chat right now, and we can ask the questions for you while you're listening. In the meantime, one more question from me. Let me just see if we've covered everything you wanted to do. So we know the MDT team decide on the treatment plan. It's not just one person. Not everybody is entitled to reconstruction because it's not necessarily good for them. How do you choose which surgery it is that they have?
Going back to the decisions I was talking about before, we're looking at the proportion, the size of the cancer versus the size of the breast, but then that's just part of it. We also talk to patients about their own lifestyle, what they want, how they want their body to function for them in the future, whether they're swimmers or whether they go on holiday to fancy glamorous places every year, or whether they don't want anybody to see their chest ever again. And those sorts of issues are very important to find out. Comorbidities are also really important. So ongoing illnesses, other medical problems will without a doubt guide us as to what we will offer, because the more comorbidities, the more other issues somebody has, the more complications they're likely to have in their breast surgery. And we don't want to be giving you complications. We want to be able to make life better for you, not worse. So that's always the baseline. And it's then a group decision. We work out what is suitable and what's an option. And if there are options, we'll give them to you and let you decide, because at the end of the day, you're living with it afterwards. But if there aren't any options and there aren't any choices, then that's also what we discuss, and we go through the reasons for that and why we've come to the conclusion that a particular procedure is the one that suits you best.
That's brilliant. That's brilliant. No questions have come through yet, but this is my last question. I feel like I've grilled you today. Sorry about this. It's just like a bank of questions that people have asked. Now they're coming to me bit by bit. So cording, can anything be done about cording?
We struggle to work out why some people get cording and some people don't. For those who don't know what cording it is, it's when you've had surgery in your armpit to the lymph nodes in the armpit, the very small, tiny lymph vessels called lymphatics that are traveling all the way up your arm and across your chest wall and from your breast and all around and draining into those lymph nodes. After the lymph nodes have gone, they can get thickened and they can get very tight and sort of angry and inflamed. It's not an infection as such. There's no sign of bacteria in there. It's just a post-surgical reaction that happens. And what happens then is it limits the ability to move your arm up, and you feel a tightness that sometimes can run all the way down beyond the elbow and into the forearm. And sometimes it can run along the front of the chest wall right down into the tummy, and you can feel very fine threads. And they are actually the little lymphatics, which are thickened and tight, and when they're tight, they shorten, and so they pull, and that causes pain and it restricts movement. And so why that occurs in some ladies and not in others is a mystery to me. I seem to use the same surgical technique on everybody, and one or two ladies out of every probably, I don't know, maybe 20 or 30 ladies, a couple may get some cording of some description, some more than others. Small amounts of cording are quite easily broken down just with simple massage.
Okay.
Now I can just rub them very gently, and although it feels like you're doing something quite destructive, they break down very easily. More thickened cording and more extensive cording often will need some physiotherapy and some much more focused massage and several sessions in order to break it down. But it does usually relax over time. It's not usually a permanent problem. I've not got anybody for whom I can think of at the moment that's got any permanent problems with cording. We just refer them on to the physiotherapy team, who will do a good job at helping to break it down with them and reduce the risk. And I also haven't, in theory, there's a risk of lymphedema developing maybe several years down the line, but in practice, I haven't seen that. Yeah, after the cording, yes. And so it's because the lymphatic vessels are damaged and they are affected by it. And that's where that can happen, maybe even years and years later, an infection in the arm, because the drainage of the arm isn't quite as it used to be.
Yeah.
Any infection then precipitates more cording and more thickening, and that's when the lymphedema can occur several years later.
Yeah, that's what happened to me. I got a wasp sting on that arm.
Oh.
And so obviously everything got sent there to get the fluid out, and yeah, there's nothing to take the fluid away, is there, because I've had a full clearance. So yeah, but it's managed. I'm here. That's all that matters. I'm here. You can deal with these things, can't you?
You're a fantastic advert. And, so positive, and it's so true.
Deal with it, don't you?
You are here, and unfortunately, every intervention that we do as surgeons, and I think people don't realise this, but we're very aware of the complications that we can create as well as the benefits that we can give. And so we try and give you that balanced view, but at the end of the day, it comes across as giving us a list of doom and gloom.
Yeah.
And so we try and balance that with the positive side, but not everybody gets all the complications. So also to tell you about them all the time can also feel a bit overwhelming.
Yeah,
and it's a balance that we have to strike to make sure that you know that we're aware of them, we're doing our best to mitigate them, but there's times when we don't know the full cause and the extent of them, and we're just doing our best to avoid them for you. But we'll help you manage them if you need to, as it looks like you've got great management there with your sleeve. And
Please tell me though, you feel appreciated more than unappreciated by your patients, you know, because yeah, they can very easily fall into victim mode, and that's what Sam's Downs is about, is taking victims and making them into survivors and then thrivers. Do you know what I mean? It's so easy for people to focus on the doom and gloom of things, but you know, what's the alternative? Me having this or not being here? Do you know what I mean? You deal with it. That's the way my mentality is, and I think that's what I'm trying to do with a lot of Sam's Diamonds, because it's the easy way is to point the finger, feel doom and gloom, and life's not fair, but actually you have a life to feel not fair with. Do you know what I mean? There's people.
Yes, I feel I'm very lucky, and my patients I don't get a sense of blame that I've caused their problems. We share it, you know, and I didn't give them the disease, but I want to be part of the treatment, and I want to do my very best to clear them of that disease as much as is humanly possible, and as much as modern medicine will allow us to do that. And that's as much as I can do, and I make sure that they know that's what I'm doing. We do our very best every time, and I would say every patient is appreciative. I'm so grateful, and that's what gives me the job satisfaction at the end of the day, is that I can see that they do appreciate what we do. They appreciate the effort that we put into it and the thought that we put into it, and I appreciate seeing them fly again and seeing them return back to their families and their holidays and all the things they were doing before this came along.
That's brilliant. That's brilliant. Well, you're doing an absolute amazing job, and I'd love to stay in contact with you. Sorry for throwing so many questions at you, but it's not very often we get to speak to a surgeon, you see, so it's like, woo, there was quite a few.
Well, thank you for inviting me. I've enjoyed it, and it's good. And hopefully I've been helpful for everybody.
You've been very helpful. You've answered all these different questions I've had for years that I've been asked myself, and I've learned quite a bit of stuff as well, especially about finding lumps with boobs in, with with implants in. So I didn't realise it would make it easier, so I can put a few people's minds at rest now. So that's really good. So thank you very much for joining us.
Pleasure.
And I will be in touch soon.
And all the best with the rest of you. All the best with the rest of your conference. I hope it goes well.
Thank you so much, Emma. I appreciate you giving us your time.
All right. Take care.
All right. Bye now.
Bye bye.